Welcome everybody. Today we are going to learn where we are in the first 2 decades of the 21st century in diabetes care. And as we know, this presentation is made on the end of September, just after the release of the joint ADA ESD management of hyperglycemia type 2 diabetes management guidelines and the consensus report which has just come out. So that is going to be the core of this talk, and I'm going to discuss that in great depth and detail. On Friday, September 23rd and today, Saturday, September 24th, at the EASD meeting in Stockholm, the Joint Committee of ESD and ADA came out with the management of hyperglycemia and type 2 diabetes. And that really is the core summary of the last 2 decades. The papers are now available simultaneously in diabetes care as well as diabetology. And the entire slide kit is ready. This was the core committee. And this had followed a evidence-based process to make the guideline. Overall, this recommendation and consensus report had a rationale, importance, and context of glucose-lowering treatment. Then it had lifestyle and healthy behavior, weight management and pharmacotherapy, which is the core of treatment of type 2 diabetes. Then precision medicine and personalized approach to treatment based on individual heterogeneity and characteristics of comorbidities was also highlighted. And ultimately putting all together to implement strategies and various key knowledge gaps and call for action was also discussed. And finally, I will then give the Indian contextualization of the same. The writing group had a base consensus report of 2018 edition and its update. And then they looked at all the published new evidence by a PubMed search of randomized clinical trial, systematic reviews, meta-analysis between Jan of 28th of 2018 and December of 2021. They looked at all the eligible publications for effectiveness and safety of pharmacological and non-pharmacological interventions in adults with type 2 diabetes. And this was ranked updated up to 13th. This was the literature review strategy they followed. And the key points to emphasize was, it was all the evidence gathered in the past 3 years. A lot of focus was on social determinants of health and systems and equality and equity of care. Holistic person-centric care was emphasized. A predominant focus of the guidance is based on weight goals as an essential component of comprehensive care. And all the evidence which was gathered from the various cardiovascular outcome trials was consolidated. This report is fully available. There were a lot of debates and dilemmas. Eventually, it is an expert opinion group. It had a review process, which was started and initiated at June 2022 at the ADA in New Orleans and completed at Stockholm. So if you look at the goals of diabetes care, there are 2 fundamental goals of diabetes care. One, prevent complications. Second, optimize quality of life. So the first take-home message is, in 2022, prevent complications and optimize quality of life. In preventing complications, we have to move beyond glucose control, which is glycemic management, to cardiorenal protection with glucose-lowering agents, weight management, and cardiovascular risk factor management. So from a glucose-centric tunnel view, we have broadened the view to cardiorenal protection, weight management, and cardiovascular risk factor management. Language matters. Communication between people living with type 2 diabetes and healthcare members is core of integrated care. Clinician must recognize language. Language of diabetes care should be neutral, free of stigma, based on facts, based on strengths, respectful, inclusive, encouraging, collaborative, and person-centric. People living with diabetics should not be called diabetics, non-compliant, or a blame game for the health condition. Social determinants of health must be addressed, which is education, income, occupation, living and working conditions, housing, education, multi-sectoral domains, shared cultural values, practices, experiences, socio-political concerns, and health disparities. And most important is behavioral, emotional, and mental well-being factors. There's a lot of inter-individual variability in the social determinants of health. Of course, glucose control is sacrosanct, but avoiding symptomatic hyperglycemia is the key. We must reduce microvascular complications. We have extraordinary evidence from DCCT UKPDS, and the best reduction is lower the A1C, the better is the outcome. There are some uncertainties related to the macrovascular benefits of blood glucose control of type 2 diabetes, which are still not totally resolved. But there is emerging evidence to suggest that harms of glucose control medications is unlikely. A1C is a standard. SMBG is worldwide available. CGM is the next evidence of care as far as monitoring is concerned. But in glucose control behavioral approach, medications, even surgery has added to the complexity of person-centric therapeutic decisions, and the risk-benefit ratio has to be weighed. Weight reduction is now a targeted intervention. 5 to 15% of weight loss is mandatory as a primary target for many people living with type 2 diabetes. And higher magnitude of weight loss is better outcomes, including 5 to 10% for metabolic improvement and loss of 10 to 15% as a disease-modifying effect and can lead to remission of diabetes, which is a very well-established fact. And even I have been involved personally with randomized ongoing control trials using twin whole body digital twin technology in remission of type 2 diabetes and cardiometabolic complications. Weight loss has excellent benefits beyond glycemic management in cardiometabolic disease, outcomes, and quality of life. Putting the person with diabetes is the center of care, center of care, center of care. And clearly, you have to assess the person living with diabetes characteristics, consider specific factors which are important in choice of treatment, have a shared decision-making dialogue to create a management plan, agree on it, implement that management plan, continue support and monitoring and review. So prevent complications, optimize quality of life, remain the same. Individual priorities, lifestyle, comorbidities, clinical characteristics like A1C weight, motivation, depression, cognition, and social determinants are the keys. Each factor has to be individualized on glucose and weight goals, weight hypoglycemia, cardiorenal factors, psychological factors, side effect profile of medications, complexity of regimens, access, cost, availability of medications. Then dialogue and discuss with the patient. And ultimately, this shared decision making, empowering, nothing without us, without talking to us, is the motto now in diabetes, or people living with diabetes. Risk, safety, benefits, personal preferences, values are very important, and maintaining autonomy and confidentiality. A lot of face-to-face interactions with educators, promoting healthy eating habits, physical activity, good medication behavior will increase self-efficacy. Because we all know structured education and a good contact time of more than 10 hours, there is evidence-based generation that A1C comes down, hospital admissions come down, improve the person living with diabetes, their diabetes knowledge, they're psychologically, they are happier patients, clinical outcomes are better, it's cost effective, and overall they live longer and all-cause mortality reduces. So it's very, very important. Then agree on a management plan with SMART goals, specific, measurable, achievable, realistic, and time-limited. Implement the management plan. Overcome clinical inertia. Overcome clinical inertia, provide ongoing support and monitoring, and agree and review the plan. So how do we do that? Well, we know. By 2030, US, half of it will be obese. 25% will have morbid obesity. Intensive structured weight management with direct trial, 10 kg in 2 years, 64%, one-third of people had diabetes remission. We have similar results from Indian RCT also from the twin trial. Weight management, drugs like step 2, semaglutide, have showed in RCT that you can remit diabetes. And now we have another kid of the block called tirzepatide, which has come up very fast. Metabolic surgery also has had a huge impact. So weight is at the center of the universe. Individualized weight management plans, general lifestyle advice, intensive evidence-based structured weight management program, weight loss medications have a high impact. 24-hour physical behavior is the key. Sitting is the next smoking. Stepping, sleeping well, sweating it out, strengthening your muscles. The 5S mantra is the new buzzword in the new guidelines. Sitting is the next smoking. So breaking up prolonged sitting is the first mantra. More steps, every 500,000 steps you add is better. Good quality sleep, at least for not less than 5 hours and at least more than 8, not more than 8 hours is the key. 7 hours of sleep. Sweat it out and strengthen your muscles is the key. So breaking prolonged sitting. Limit sitting and breaking prolonged sitting every 30 minutes. So after my talk, please get up and do some simple bout of brisk walk. Sweat it out. Sweat it out. Try to focus on frailty phenotype. At least in earlier age, the sarcopenia, and manage muscles better. Add only 500 steps per day. 2 to 9% decrease in cardiovascular morbidity and mortality. 5 to 6 minutes of brisk walk will reduce the 4-year life expectancy. If you build muscles, and even yoga can improve flexibility and balance. Good quality sleep. Sleeping on time and not more than 8 hours, not less than 6 hours, 7 hours is the key. Metformin is still there. It was traditional first line, but that has been challenged. High efficacy, minimal hypoglycemia, modest weight loss, good safety profile, low cost. Secretagogues, non-durable, inexpensive, accessible, high glucose lowering efficacy agents, but a high group of hypoglycemia. CV, MACE outcomes, well, not relevant. Glitazones, great drugs with durability, beneficial effects with NASH, but weight gain, fluid retention can still be a challenge, which can be mitigated by SGLT2 inhibitor combination or GLP-1 receptor combination. Gliptins, intermediate on glucose lowering effects, neutral on the weight, very well tolerated, minimal risk for hypoglycemia. Very finite trials have shown metformin with a gliptin can increase durability rather than a stepwise approach. Hit hard, hit early. CV safety has been documented. The kids out of the block. The statins of this century, as Eugene Grunwald, the famous cardiologist, said, is SGLT2 inhibitors. Intermediate to high efficacy, no hypoglycemia, intermediate weight loss, efficacy on CV effects seen in most people, and heart failure evidence is robust. Renal benefits on DKD is robust. And clearly, it is a standard of care now. Safety issues still need to be addressed. We have generic SGLT2 inhibitors. GLP-1 inhibitors or agents are great agents. High efficacy, very good weight loss, no hypoglycemia, neutral on the heart failure. Kidney benefits are not very well documented. Safety value is high, and it is emerging agent of choice. And now we have the oral semaglutide, which is having very good data in advanced type diabetes, established diabetes, and early diabetes with global trials. And this agent, as well as dulaglutide and semaglutide, as well as various other trials, have shown that the glycemic impact is huge. And then we have the dual agent, which is surpassing even the GLP-1s. The GIP GLP-1 tirzepatide has surpassed expectations because it has very high efficacy, very high weight loss, emerging yet under investigation on heart failure, MACE, and progressing to CKD, and might just be the agent which may be the game changer. But more evidence is needed. After 100 years in the 102nd year of insulin discovery, it is still the longest surviving anti-diabetic agent. High to very high glycemic efficacy. Hypoglycemia risk is always there. Weight gain risk is always there. Neutral cardiorenal profile. Across board, very good physiological safety. But the current trend is combine, combine, and combine. Durability, multiple pathophysiological effects, reducing metabolic burden, medication burden, adherence and persistence, and complementary mechanisms of actions. So we need to look at all these agents: weight management goals, glucose lowering goals, dulaglutide, semaglutide, tirzepatide, and high doses glucose lowering, insulin combination therapy, very, very high. Personalized approach is the key for each individual phenotype and comorbidities. So again, if in the decision cycle, look at the patient's phenotype, assess it appropriately, and then look at the evidence base. What is the grade of evidence? The grade of evidence is if there is atherosclerotic vascular disease or high risk in the pecking order, it is GLP-1 receptor agent or SGLT2 inhibitor with proven cardiovascular benefit, or either or. If it is heart failure, it is clearly SGLT2 inhibitors. If it is DKD or CKD, it is SGLT2 inhibitors clearly there. Or any other agent with proven cardiovascular benefit or cardiorenal benefit. So clearly with CVD, it is GLP-1 receptor agent and or SGLT2 inhibitor, and vice versa. Glitazones are also there in that category. People with established cardiovascular disease, a GLP-1 receptor agent with proven benefit should be used to reduce MACE, or a SGLT2 inhibitor with proven benefit should be used to reduce MACE, heart failure, and improve kidney outcomes. People without established CVD, with multiple cardiovascular risk factors like 855, obesity, hypertension, smoking, dyslipidemia, albuminuria, GLP-1 receptor with proven benefit could be used to reduce MACE, or SGLT2 inhibitor with proven benefit could be reduce MACE, heart failure, and improve kidney outcomes. That is the standard of care. And this is all individualized. Look at all-cause mortality, non-fatal MI, non-fatal stroke, end-stage kidney disease, and hospitalization of heart failure. Look at the add-on as metformin and look at the recommendation of the consensus. It's a recommendation. It's not a guidance. ACE will come out with guidance next week. In heart failure, CKD, established CVD, or multiple risk factors, it is GLP-1 receptor agent or SGLT2 inhibitors with proven benefit on background of metformin. And in heart failure, CKD, established CVD, or multiple risk factors, it's again either all of these two agents. Heart failure, it's SGLT2 inhibitors all the way. Unloader of the heart, whether it's DAPA-HF, Emperor Preserved, clear data. In the kidney outcome also very clear data. So when it is DKD or heart failure, the pecking order of SGLT2 inhibitors is right up there. Very good kidney data. Redens, prematurely terminated trial. DAPA, CKD, EMPA kidney. Very, very good data. So clearly in CKD, it's SGLT2 inhibitors, and of course GLP-1 receptor agents have yet to prove their benefit there. Age is important. Older age, senior citizens, frail have worse outcomes. And therefore don't hit hard older people above 65 and younger people below 40 are underrepresented in clinical trials. Most of the clinical trials are done between 40 and 65. So whenever you're doing decision making with people above 65 or below 40, there's a limitation on when you discuss there because of age-specific data. Age is important. Age is very important. Above 65, below 65, data is different. So when you are selecting agents which improve cardiovascular and kidney outcomes, it should not differ for older people. But if somebody is frail, multiple comorbidities, you have to look at safety and tolerability. And don't over-medicate and cause hypotension and hypoglycemia. That is a clear warning signal. Rates of prediabetes and type 2 diabetes are exponentially going up in the adolescent world and the young adults. And hit hard early because young people rapidly deteriorate and they need very good control. And that's why it's important that early combination therapy, particularly in the younger age group, is preferred. Fatty liver, obstructive sleep apnea, heart failure, all can be modified by weight loss alone. And also race. We are Asians, women, gender, ethnicity, all this should be considered by decision making. And therefore, putting it all together, a holistic person-centric approach should be used for type 2 diabetes management. Not just one step of complication prevention or optimal quality of life. In the component, it is medication for glucose control, weight management, cardiovascular risk factor management, and cardiorenal protection. And all that has to be integrated with surveillance and screening, health behavior, monitoring, reduction of hypoglycemia, communication, overcoming inertia, social and psychosocial determinants of health, and of course, language matters, and involve the patient in the shared decision making. So glucose control matters. Metformin or agents, including combination therapy, can make a difference. Avoid hypoglycemia, particularly in the high-risk individuals. Ensure weight is the key, including meal replacement. Look at the big five: cardiovascular risk factors, screening and surveillance, blood pressure lowering, lipid lowering, antithrombotic agents, and tobacco and smoking cessation. These five are the next five. After the five in the lifestyle, cardiovascular risk factor, blood pressure, lipid, antithrombotic agent, and tobacco and smoking cessation. Look at cardiorenal protection. ACRB always there, but SGLT2 inhibitors are right up there in the pecking order of the cardiorenal protection, apart from GLP-1 agents. So therefore, we have the full plethora approach: glucose-centric, weight-oriented, the big five of cardiovascular risk, blood pressure lowering, lipid lowering, antithrombotic agent, smoking cessation or tobacco cessation, and of course, heart failure and kidney failure, SGLT2 inhibitor, GLP-1. That is how this matrix and the new guidance is there. It is healthy lifestyle behavior, diabetes self-management education, social determinants of health. Look at heart disease, high risk, heart failure, kidney disease, glucose control, weight management, and mix and match. Every patient has not to be counted as a person living with diabetes. Respect him, handle them mindfully, engage them in the decision making, make them happy and healthy. So integrated care, it's a lifelong approach. Try to have a team, use all the local resources, speak in the local language, use each person a precision personalized signature for that person. Try to see the best evidence and the best available access. Look at socioeconomic determinants. Look at comorbidities. Look at education holistically. Look at promoting healthy behavior, happy behavior, physical activity, glucose activity, tracking activity, with all the apps here. If there are hypoglycemia lowering agents like insulin and sulfonylureas, educate them with nutritional modulation to avoid severe hypoglycemia and use MNT appropriately. Choose agents with efficacy, safety, comorbidities, weight, age, frailty, life expectancy, cognitive impairment, their pocket, hypoglycemia, volume depletion, genital infections, pancreatitis history, and prioritize organ protective medications like litazones, SGLT2 inhibitors, and GLP-1s. Look at cardiorenal and NASH impact of these people. Insulin still has a role, but GLP-1 agent can be used before insulin. When initiating insulin, start with basal insulin and then titrate accordingly. Insulin, when initiated, continue organ protective glucose lowering medication with metformin and keep educating. There's a clear place for insulin. If not on a GLP-1 receptor agent, start with basal units, 10 units at bedtime or 0.1 to 0.2 units. Target fasting glucose either through SMBG or CGM, and then keep them in range. You can have basal plus, you can have premix, you can have multiple doses and basal bolus insulins. There is a place for technology. We need technological declutter, but it is useful CGM is going to be standard of care in people with insulin. And you need to mix and match and not make them distressed and depressed because of technology. We have to improve care. We have to give education. We have to be constantly being connected with mental health specialists, psychologists, other specialists, including ophthalmologists, and tailor it to the local setting. Ensure information, communication, translation, accountability is there, and work with the healthcare system. You and me have to make it work to make lives of people living with diabetes healthier and happier. That's the goal. And therefore, the call for action is try to get them empowered. Try to ensure that if they're young, if they are frail, if they are senior citizens, if they are gender balance, weight, A1C, time in range, weight, and remission are the key targets. Look at cardiorenal protection, combination therapy, and cost effectiveness. Look at comorbidities, fatty liver, cognitive impairment, advanced CKD. Look at technology, sleep, and phenotype. But be empathetic, sympathetic. Try to have a person-centered decision-making. Try to improve behavior of nutrition, activity, and self-monitoring. Acceptance, adherence, persistence. Supporting cardiorenal health, cardiovascular risk reduction is the key. And at the end of the day, we want to make them live longer with evidence-based guidelines. So today's approach for people living with type 2 diabetes, particularly in the Indian context, is not to be glucose-centric. Glucose is a small component. Weight-centric, cardio-centric, renal-centric, and we need to move from the glucose-centric approach to a weight-centric approach, cardio-renal-centric approach, and an affordable, accessible approach with happiness, positivity, empowerment for the person living with diabetes. Prevention mantra is the key. My mantra still remains: eat slowly, eat less, eat on time, and eat right. Walk as much as you can. If you can do physical activity, great. Be fidgety, do yoga or pranayam, take deep breath, sleep well, and sleep on time. The chronotype is as important as phenotype. And don't get stressed out. Always smile. 1 hour of digital detox, whether it is a computer screen, whether it is the television screen or your mobile screen, will make you happier. Engage in hobbies which promote physical activity, which promote happiness, which promote positive health. We are all committed to health and happiness. So I hope from this presentation, you have listened to me. You have learned some evidence base as latest as of 23rd September 2022, and hopefully you will adapt it to help people living with diabetes to live longer, to live without complications, with good quality of life, with health and happiness. Thank you so much for a patient hearing.